Hello there, this is Asin Hussain. I'm an assistant professor in the Department of Ophthalmology and Visual Sciences in Dalhousie University in Halifax, Nova Scotia. And here I shall be discussing with you melanoma of the eyelid area. So I had this patient who was sent to me for ptosis, left worse than right ptosis. And he was a 65-year-old man who walked in and actually at the time had a big bandage over the right lower lid. And I said to him, why is this big bandage here? He said, I've had this scab for a few months and it's not getting better. I showed the GP and the GP sent a referral to someone. So I said, okay, we just carried on with the examination and I finished the exam with a ptosis and, we diagnosed an involutional aponeurotic ptosis. Anyway, I said, let me have a look at this scab because it's quite close to your eye and your eyelid. So let me see what's going on. And there it was. So there's this big darkish lesion with ulceration and some subcutaneous changes and swelling as well. So, alarm bells ringing, thinking, well, this is, melanoma probably until proven otherwise, although there are some other differentials. So whenever you see a patient with a dark pigmented lesion around the eyelid, there are some various differentials you have to think of. And what I'm going to do here is talk to you about periocular and eyelid melanoma. So first of all, the etiology of this tumor. Let's go back a bit here. What is a melanoma? Well, it's the malignant transformation of skin melanocytes that we normally have in our skin from UV-induced DNA damage. And we know that tumor suppressor genes are involved, such as the BRAF oncogene and the KIT oncogene that can be in your exam, and you should be aware of that. These lesions can arise de novo or in predisposed lesions such as a cellular blue nevus, and we published an article on that in the CJO where a patient had a large cellular blue nevus around the orbit and actually had melanoma within it. This is also called a nevus of Oda. And a dysplastic nevus is another pre-existing lesion which can lead to a melanoma. Epidemiology, well, it's quite rare, thankfully. Accounts for less than 1% of eyelid malignancies. It is more common in older individuals. And the mean age of presentation is around the 6th decade. It rarely occurs in non-Caucasians. And probably because of increasing awareness, there has been a threefold increase in diagnosis in the last 4 decades, but also maybe because, we're now seeing patients with cumulative sun exposure, which is the key phrase which should be asked to patients whenever you're thinking of a malignant eyelid lesion. Ask them about cumulative exposure. So over your lifetime, have you had significant sun exposure? Have you ever had blistering sun exposure? Very important question to ask. This tumor, melanoma, has an equal gender distribution, and it is the 5th most common cancer in the United States. So clinical presentation. Well, as with any other periocular or eyelid malignancy, in the history, there are some key features. I mentioned to you about age and sun exposure. You should ask about a history of any other skin cancer. Doesn't have to be in the eyelid region, anywhere on the body. You should ask about the characteristics of this lesion in particular. Has it grown? How quickly has it grown? Does it bleed? Does it itch? Does it cause any pain? If it causes pain, it's unlikely to be a malignancy as such. Usually the painful lesions are the inflammatory lesions, which are more benign, but never say never. Sebaceous gland carcinoma, for example, can cause a secondary inflammation and may cause some pain or blepharitis. Also ask about immunosuppression. Is the patient on steroids? Do they have a history of transplant? Are they on any of these fancy medications which patients are on for post-transplant? And those patients can present with multiple periocular and skin malignancies. In a patient with light skin and hair and light blue eyes, they're the typical ones with the Fitzpatrick skins type 1 and 2 who get these kinds of tumors. Plus, be aware of genetic syndrome. So in your exam, you may be asked about xeroderma pigmentosum. Wiskott-Aldrich is another one. which can lead to multiple eyelid malignancies. And you know of basal cell nevus syndrome or Gorlin syndrome, which leads to multiple basal cell cancers. So clinical features. Typically a melanoma, when it presents in the periocular lesion, periocular region rather, it causes tissue destruction. So if I go back to the picture here, this is actually away from his eyelid, but if you look closely, it has caused distortion of the anatomy of the skin. There's ulceration. If it was on the eyelid, you may see madarosis. There's an irregular border, although from this picture, it looks quite circular, but actually there's an area around it which is much more irregular. Another key feature to look at the photo is heterogeneous pigmentation. So you'll know about the ABCDEs of dermatology and pigmented cancers. I won't go through them, but the first two, asymmetry, border, and the contour and color. These are the important factors. Be aware that melanoma can present in an amelanotic fashion without pigmentation. So you can get patients with a non-pigmented lesion, and that could also well be a melanoma. So jumping on to testing, how would you make your diagnosis? Well, first of all, clinically, but then you most likely will have to perform an incisional biopsy. And in this patient, right there and then in the office, I did a punch biopsy of the peripheral part of the lesion. I always tell residents, try not to biopsy the central part. You may just get necrotic tissue because that's where the tumor is probably dying. It grows around the edges. So try to get one edge and draw in your notes where you took that biopsy, because when you go into surgery, you might not remember, and you'll need to know when you do the actual excision. There are certain high-risk histological factors. So when the pathologist looks at your incision biopsy, which you should try to do as deep as you can with a punch biopsy. And why is that? Well, because the pathologist will have to do a Breslow thickness. They'll have to look at ulceration, mitotic figures, perineural invasion, and lymphovascular invasion too. Because the single best predictor of survival in these patients is the depth of invasion and the Breslow thickness. We use the American Joint Committee of Cancer Staging Manual, which I have up in my office, which guides you in terms of prognosis for these eyelid tumors. And when you're, of course, suspicious for orbital involvement, do your CT or MRI, which will assist in surgical planning. Also be aware of sentinel and lymph node biopsy, which you should consider for large lesions as per the AJCC criteria. And the eyelid melanomas, they go to the parotid, submandibular, and cervical nodes. So in this patient, I'll show you a picture here. This is intraoperatively when we operated on him with the ENT surgeons. You'll note this bluish hue below the specimen. That's the injection of the dye to track for the sentinel lymph node biopsy. Fortunately, he didn't have that. That was somewhat surprising. But we performed a neck dissection, and we didn't visualize any nodes either. And that's the sort of the circle with the large marking on the skin. That's the extent of excision that you have to perform. You know, it's almost a centimeter. And he had to have a large advancement and Hughes flap for reconstruction. And he did very well. And then he went on to have his ptosis repair. So I'll just run through some treatment options. I've said to you about sentinel lymph node biopsy. That should be considered for any lesion over 2 millimeters in Breslow thickness. And if the patient has a positive SLN, they will need a complete neck dissection and possible radiation. They may also require some of these new drugs, the immunotherapies you'll have heard of. Ipilimumab and nivolumab are very popular now for systemic melanoma. You may need to consider radiation. You'll have to get your friendly neighborhood oncologist involved. And you may want to do molecular testing for the oncogenes, because there are some experimental immunotherapies now in place for people who are positive for some of these oncogenes. And then follow up, the rate of recurrence after a complete excision is between 1 and up to 25%. So the patient should be followed for every 3 months in the first year, and then every 6 months for the second year, and up to 5 years they should be seen. I always palpate the lymph nodes in all my patients who I think have a malignancy around their eyelid. It takes 2 seconds. If you feel something, investigate that either through the GP or sending the patient to an oncologist, but it should be part of your office examination of your eyelid patient with a possible malignancy. And other investigations like neck ultrasound, CT I've mentioned are very important too. Okay, that's the end of that one.
So I just had a couple of questions in terms of the initial incisional biopsy that we do. You mentioned that the thickness of the biopsy was important. If the lesion is on the eyelid proper, do you do a full thickness incisional biopsy, or do you just go deep to where you can see the pigmentation? If there is pigmentation, how do you guide that initial biopsy?
Yeah, so if the lesion is at the eyelid margin, I would not want my incision biopsy to be considered curative. So really it's to make a diagnosis. So I would probably take the smallest, which in my office I have a 2 millimeter or even a 3 millimeter punch biopsy. And you should, hopefully, you'll be able to take a peripheral segment of that lesion away from the lid margin. I would probably not take it at the lid margin. You'll cause just a more anatomical disruption and affect your actual excision. But the key is to try to get an area where you think the lesion is, but also try to be deep down to muscle. That's usually safely done in the office with some local anesthetic. But the bigger biopsy you can give, the better. If you have a large lesion this size, I did a 5 millimeter punch biopsy in the peripheral part of the lesion, involving both the nodular component and the more just non-elevated pigmented component. So I got both in my specimen when I did the biopsy.
Thank you. And a lot of these patients are quite nervous even after they recover from this. And so I think it's pretty standard that oculoplastic specialists will follow them for about 5 years. But after that, if patients are still a little bit nervous of a recurrence, what frequency of follow-up would you recommend with either an optometrist or a GP?
I think it would be fair to say that in the first 2 years, even a 3-monthly follow-up would be fair, either through the GP or if you can get a dermatologist involved, which I probably would in the early stages with a patient with a melanoma, because they may have other non-diagnosed areas on their skin. So I would get a dermatologist involved if they want to see their GP as well. You can mix and match their follow-up, seeing the dermatologist maybe every 6 months, seeing you every 6 months, so that hopefully if you could do it, then you'll be seeing someone every 3 months or so. I think that's fair. I think it's fair to be anxious, and the patient can also, of course, self-monitor. Tell patient, you should be doing a skin exam yourself. And if you ever notice, whether it's now or 5 years from now, a lesion changing, considering your history, you must seek help earlier rather than later. Yeah.
Thank you.
Thank you.